Okay. So the nursing process. The nursing process is really a decision-making framework, and it's the foundation of our nursing practice. This is very purposeful, it's goal-directed. It's the systemic way that we can achieve our optimal patient outcomes. And we use this as a method to organize our patient care. We like this because it utilizes our critical thinking, and the process is based on reason. So it's very systematic in how we approach our patients and devise our plans of care. It allows us to make very unique plans of care, whether it's for an individual, for a family, or for a community. And most importantly, it really differentiates us from the practice of medicine and other healthcare roles. Because as nurses, we take a holistic approach, whereas in medicine, they take a very disease specific approach when they're caring for patients. This is why patients benefit from a blend of both medical and nursing care, very unique from one another. There are 5 steps to the nursing process, and they're cyclical or continuous. The 5 steps can be remembered by the acronym of ADPI, which is assessment, diagnosis, planning, implementation, and evaluation. As we're doing this, we get to that last step, evaluation. Did the plan work? And if the answer is no, we have to go back and start this all over again. If the plan is yes, this is great, but we still have to start all over again because we have to keep reassessing our patient to make sure that it is still going to be correct for that patient. So when we look at assessment, what is assessment? Assessment is the data that we collect. It's information about the client's present health status. We can collect it during that initial assessment, during a focused assessment, and during ongoing assessments. Methods of data collection are many. We use observation. We look at a medical history. We complete a head-to-toe exam or focused physical exam. We look at diagnostic and laboratory reports, and we collaborate with other members of the healthcare team. To collect data effectively, we have to ask the right questions. That's very important, and we need to listen very carefully to the patient's responses and have those excellent assessment skills. As nurses, we collect both both subjective and objective data from primary and secondary sources. Primary subjective data is obtained directly from the client, and it includes the client's feelings or their perceptions and their descriptions of the health concern. Primary objective data is obtained via the nurse's senses to look, listen, feel, and smell. So remember, subjective is what the patient says, and objective is what you can measure or what you've observed, what you're able to see. Some good examples of that are diminished lung sounds or a patient who's unable to speak in full sentences versus the patient who tells you it's hard to breathe. Secondary sources are other people or the medical record. Subjective might be from a family member. My wife was awake all night coughing. Objective might be an X-ray report or diagnostic lab in the chart that identifies that the patient has an infiltrate. We assess our patients really the second we walk in the room. Soon as you walk in a room, if you see a client in bed, you're assessing them. You're assessing their level of consciousness. You're assessing their posture. Are they laying in a bed or stretcher? Are they sitting upright in a chair? Are they flopped over on the side of the bed? Do they make eye contact with you? Are they able to verbalize? Are they able to speak? Is their speech clear? Is it concise? Is it coherent? Or is it slurred? So the second you walk into a room and say hello and introduce yourself, you're actually starting your assessment data right then and there. So when we look at the diagnosis, our nursing diagnosis helps us identify what is the problem. Nursing diagnoses are developed based on data obtained during the assessment, and they help us kind of drive and develop that plan of care. A nursing diagnosis can be problem focused, it can be a risk potential, it could be a health promotion, and it helps us set priorities for our nursing interventions. It provides a basis of evaluation to determine if our care is going to be beneficial to the client. And I'm going to talk today about using NANDA International Diagnoses because I believe these are ones that you're all familiar with. What I love about NANDA, you're using that in Sierra Leone, and I am using that right here in New Hampshire in the United States. I love that it's something that crosses all geographical areas of nursing. It's kind of like we talk that same language, and it's a standardized language, which is fantastic. And it forms a basis of communication, not just between ourselves as nursing professionals, but with the healthcare team itself. Nursing diagnoses are really directed towards the client's physiological and psychological responses. Is very different from a medical diagnosis because a medical diagnosis is very particular to a disease or medical condition, and it centers on the illness. Again, if we have a patient who has shortness of breath, one of our nursing diagnoses might be ineffective airway clearance or an ineffective gas exchange, whereas a medical diagnosis is going to go straight to pneumonia, or it's going to say upper respiratory infection or maybe COPD. When we plan care for a patient, really that's how are we managing their problem. And we like to establish our priorities using Maslow's hierarchy of needs. Clearly, they need to have basic needs such as food, water, actually the ability to breathe is going to be more important than when we get up to self-actualization. And it's more important just as in a matter of priority, and it helps us establish those interventions. We start out with an initial plan and know that modifications might be needed, especially when we get to discharge planning. It's really unique, and it requires us to anticipate those needs after that patient's discharge. It's also important that we set realistic goals for this client in the planning stage. Really, I want you to focus on that word realistic. A patient who has pneumonia, a realistic goal might be setting a goal for them to ambulate 10 meters 2 times per shift. If we say you're going to ambulate 5 kilometers and they have pneumonia, that's not really very realistic, is it? Okay. So we really want to consider those holistic aspects when we are driving that plan of care. Implementation's all about putting this plan into action. And this stage is when we implement those interventions that we have created in the plan, such as the patient will ambulate, the patient will use the incentive spirometer, the patient will. Also, part of this could be technical skills such as blood pressure monitoring, could be therapeutic interventions such as wearing PPE to protect the client. It also can be therapeutic communication with the client, the family, or the community. As nurses, we might perform those actions and interventions ourselves, or sometimes we might be delegating those tasks and supervising other healthcare workers, such as vital signs and a stable client, or maybe assisting with delivering a meal tray or assisting a client to eat. A key step in this implementation stage is to document that client's responses to the care. And all care should be implemented based on an evidence-based rationale, including caring and professional behaviors. Again, we want to think about that priority order. But we also know as nurses, with our time and our workload, we have to delegate some tasks. We might not be able to deliver all of our care ourselves. So what can we safely delegate? That's very important. And I want you to think about what aspects of this you would document. I'm going to talk a little bit more about documentation further on in this presentation. When we look at the evaluation stage, we really want to identify if our plan worked. Nurses evaluate the client's response to the nursing interventions and form a clinical judgment about the extent which the clients have met the goals and the outcomes. Nurses continuously evaluate the client's progress towards measurable outcomes. Questions to consider: did the client meet the planned outcomes? Were the nursing interventions appropriate and were they effective? Does the plan need to be modified? Factors that can lead to a lack of goal achievement include incomplete data, unrealistic client outcomes, or non-specific nursing interventions. Also, inadequate time for that client to achieve the outcomes. If the goal is not met, you're going to return to stage 1 assessment. What is documentation? We're going to jump into this topic now, and why is it important? I really like to talk about documentation when we talk about the nursing process because I really feel strongly that they do go hand in hand. Documentation is the record of your nursing care. It's the primary way that we as nurses demonstrate what we did, for whom, when, and with what effects. Documentation encompasses every conceivable form of recordable patient data and information, from vital signs to medication administration, records to narrative nursing notes. Remember, documentation is a legal record. It's not just merely record keeping. And the documentation that comprises the patient's medical record is also a legal document. It therefore means it's a means for others to assess measures of whether that care was received or not, and if it met professional standards of care. We like to use the term, if it wasn't documented, it wasn't done. That is your proof that you did your work. It qualifies what you did. From a professional and legal standpoint, it's very important. It's how we prove, like I said, what we did or what we didn't do in the course of caring for our patients. And for this reason, documentation it's not peripheral to your job as a nurse, it's actually very central to it. It's one of the most important components of care that you provide. When we look at documentation principles, nurses document their work and outcomes for a number of reasons. The most important is for communication within the healthcare team. The American Nurses Association has identified 6 principles of nursing documentation that provides guidance for high quality documentation. And even though this was from the American Nurses Association, I truly feel this is applicable everywhere. This is how I document when I go to Ecuador, just as like you should be documenting in Sierra Leone. Principle 1 has to do with the documentation characteristics. High quality documentation is accessible, meaning somebody who needs to look at it knows where to find it. And this is applicable whether you document on paper with handwritten notes in a paper chart, or if you document on a computer, an electronic medical documentation. The people who need to read these notes have to have access to whatever method you're using to document. It needs to be accurate, needs to be relevant, and it needs to be consistent. You don't want to have large gaps or large breaks of time that are unaccounted for. Needs to be auditable, clear, concise, and complete, legible and readable. I have to ask you, do the providers in Sierra Leone have as bad handwriting as they do in the United States? I can't read my provider's notes half the time. Has to be legible and readable, neat handwriting. Needs to be thoughtful, timely and sequential, reflective of the nursing process, And it needs to be retrievable on a permanent basis, meaning you can go back in time and retrieve these records. Nurses in all settings and at all levels of service must be able to provide comprehensive education and training in the technical elements of documentation in the organization's policies and procedures that are related to the documentation. This should include staffing issues that take into the account the time needed for documentation work, to be certain that it fits within your workload and that you are capable of functional and skillful use of the documentation system. We must consider that paper documentation systems require access to adequate writing materials, such as paper and an ink pen. Just as electronic documentation means you need to have access to a computer and receive the education and training on how to use that. The nurse must be familiar with the organizational policies and procedures that are related to documentation in your facility and apply these as part of the nursing process. We must consider that paper documentation systems require a system for collating those nursing notes in the form of a paper chart or a patient chart. You can't just have notes spread all over a desk or shoved in a file cabinet drawer. There needs to be a systemic way to organize these. There needs to be security and protection of these notes. And it needs to be built in at the organizational level. We want to protect our patients' identification, confidentiality of their information, also confidentiality of the healthcare workers' information and of the organization. Depending on your setting, you might have policies within your hospital. There might be government mandates. You might have laws in your country that designate how to secure that data and protect the patient's identification. Also, we have our accrediting agencies that we want to be mindful of, that we're meeting their standards. When we talk about the documentation entries, this is what we actually write in there with our notes. This also includes provider orders. It's very important that our documentation is accurate and it's complete. It's truthful. We need to be able to identify who the author is and be assured that nothing has been added or asserted after the fact. It needs to be dated and time-stamped by the person who created the entry. Again, needs to be legible and readable. And we want to use standardized terminology, including approved acronyms and symbols. I know years back in the United States, we used all sorts of medical shorthand, and that can become problematic because the person who might be reading or interpreting the note might not recognize that. So I want you to think about what the process is in your facility and if you have standardized terms and use of those terms, symbols, and acronyms. Also with standardized terminology, this helps us permit our data to be aggregated and analyzed. So again, back to that data audit. If we want to assure that 100% of our patients had a full set of vital signs upon their initial admission to the hospital, the terminology needs to be standard or we're not going to be able to locate that information in a chart. Okay. Very important when we think about diagnoses. We're talking about a patient with diabetes. We don't want to substitute the lay term, the sugar, in our documentation or in our chart, because if we're looking for patient with diabetes, that could fall through the cracks and not be picked up. It could also impact our care of delivery if that patient has symptoms of hyper or hypoglycemia. So again, very important to have those standardized terminologies. I'd like to now review just some practical tips and a summary for documentation. Avoid abbreviations, acronyms, and medical jargon. Keep in mind that the documentation might also be read by the patients or individuals without clinical training. Not everybody might know that the letters HTN means hypertension, or the letters VSS could refer to vital signs stable. We want to avoid any confusion because we want to actually spell those words out. We also want to avoid vague terms and generalizations. When you document, you want to be very clear and specific as much as possible. For example, don't use vague terms like small to describe a wound or to quantify the amount of bleeding. Instead, use an objective measure. This here is a wound measurement guide that I just put up here as an example. A specific way could be to document there's a stage 2 ulceration on the plantar aspect of the left foot that measures 2 centimeters by 1.7 centimeters surface depth. No drainage or tunneling present. See the difference between that and saying they have a small wound on their foot? Now, the next shift, the next nurse, or even you returning the next day when you're assessing that wound again, you're able to determine, is it the same? Has it gotten worse? Has it gotten better? Because you have something very measurable to compare it to. Can do this with fluids as well. 5 milliliters of sanguineous drainage noted on an abdominal dressing gives you a lot more information than saying a small amount. For meal intake, the patient ate their whole meal. That doesn't tell us a whole lot because we don't know how much was on the plate to begin with. They could have had a very big appetite or a very small appetite, depending on what was delivered. So really using percentages, the patient ate 100% of the meal provided, or 50% of the meal provided, or 25% of the meal provided, really will give you a better indication as a quantifiable measure. Other practical tips. Really important to document only what you did or what you observed, and do not document your opinion. Sticking to the facts. For instance, you should never chart something like the patient was uncooperative, will not take medications. Instead, simply write patient refuses medications. If the patient is rude or inappropriate or even hostile, you don't want to put those subjective judgments in your notes, but you can factually write that the patient made verbal threats towards myself and other staff members. Per the hospital safety protocol, security personnel was called to the patient's room. That would be a factual way to state something like that if it were to happen. You should also try not to judge the patient. You want to be non-judgmental in the words that you choose. If you have something, if the patient is refusing care or being obstinate to care. It's also important that you document the care and not conflicts with others. That includes conflicts between yourself and other departments or other medical professionals. You want to be factual and you want to be professional. A good example of this is if you were unable to give a medication because it was unavailable from the pharmacy. Maybe the pharmacy was backed up. Maybe they were short-staffed. Maybe they were running late. Maybe they had an emergency. All of these factors can play into why a medication was not available. And you simply could document that. You don't want to write the medication was not given because the pharmacy couldn't provide it on time. That's casting blame or dispute or conflict on the other department. But you can factually say the medication was not given because it is currently unavailable from the pharmacy. It's also important to only document the care that you performed. And I know this sounds obvious, but it does bear repeating. Never document observations that you yourself didn't make, medications that you didn't give, and care that you didn't perform. It's unethical and it's fraudulent. The nurse before you could be giving you a report and say, oh, I gave the patient their medication and I forgot to chart that. Can you do that for me? And you have to be able to say, no, unfortunately, I cannot do that for you. You're going to need to document that yourself before you leave. Or you're going to have to do a time back documentation on that. We also want to document in a timely manner, and we want to try to document as soon as possible after we perform the care. Because remember, this is central to your role as the nurse. You do not want to get into the habit of waiting to the end of your shift to document all of your care for the shift. Yes, there are going to be times when we're busy and we're playing catch up at the end of our shift. I think that's the nature of our job. But we don't want to rely on that. We don't want that to be a pattern. You really want to document as soon as you can. I know I always actually try to document in the patient's room. I like to have a computer in the patient's room if it's available, or I like to have my patient's chart with me in the room, and I can document right at the bedside. Or I can leave the room and go immediately to the nurse's station and try to document there. Early and often throughout your shift. We also want to avoid spelling and grammatical errors. These errors can be distracting and it can make our charting appear very messy. It can be unprofessional, and some people could perceive that as unreliable. When we chart on paper, you only want to use black or very dark blue ink because other shades and colors make it difficult to photocopy if these records need to be transferred to another facility. Also, you never want to use pencil because it can smudge, be difficult to read, and it also can be fraudulent if somebody erases it and puts in someone else's information in between. You always want to end your documentation at the end of the line and not partway through that. And I have an example of that here. You can see the words with water, and then I draw a line through the empty space and sign my name at the very end. It's important to remember that the documentation is not just for your eyes, but for the next person coming in, and it's also a legal document. Sometimes there's a typo, there might be a mistake, but there's a proper way to correct that, and I'm going to show you. We want to correct mistakes appropriately. You draw a single line through the error, and you initial beside it. Don't scribble over it. Don't use an eraser. You don't have to write mistaken entry. You can just write the word correction. So for example, I crossed off the word right and I initialed it in that top line. Then in the bottom, I made a correction. Correction to previous note. Patient states pain in the left lower leg. And re-sign it. So this way here, it's very clear. It doesn't look like you omitted information. It looks like you made an honest error. You can still see the original word was right because I didn't scribble all over it. I drew the one line through it and I just simply made a correction to my documentation. These here are some references that you can all use. This was the American Nurses Association and some other internet references that are really good to help with documentation. And at this point, I would love for you to share some examples with me before I bring you to the next document that we're going to talk about today. Did anybody bring an example of their nursing notes that they're willing to share? Let's share my screen again. And we're going to talk about, this is organized as a head to toe assessment. And I want you to think about all of these qualities in your patients. Again, you're walking in the room. The first thing you see is what does their general appearance look like? we want to, again, try to use medically appropriate terms. Do they look emaciated? Do they look like they're wasted? Do they look cachetic? If they're overweight, you would want to use the term obese in your documentation. Sometimes they may look acutely ill or may not look acutely ill. Do they have jaundice? Do they have pallor? Are you noticing cyanosis? What is their level of consciousness? Are they alert, fully awake? Are they semi-conscious or stuporous or comatose? This is one of my favorite terms, number 5. How many people have you ever seen that pretend they're unconscious? Have you ever seen that?
Yes.
Yes. We can't use the word pretend in our nursing notes. That's judgmental. But we can say they have feigned unconsciousness. Isn't that a great term? Okay. We want to talk about, again, and this relates to our lady who just talked to us about the emergency room. How did they arrive? Were they walking? Are they ambulatory? Are they ambulatory independently or with assistance? Were they carried in somebody's arms, such as a child? Did they arrive on a wheelchair or a stretcher or an ambulance? If they're lying in a stretcher or an ambulance, are they resting? Are they sleeping? How did they arrive to you? I want you to think about their positions. Supine, lateral, Fowlers, semi-Fowlers, lithotomy, knee chest, Trendelenburg, prone. If you're saying somebody's on a stretcher, you should also note what position they are in. Okay, give the reader of your note the visual of what that patient looks like. We're going to start using our senses. We just used our eyes above. Now we're going to use our nose. We need to comment if odors are present. And again, how can we write this nicely in a note and more professionally? It is okay to say that there's an offensive or a foul odor or an aromatic, fruity or sweet. We talked about that patient who might be acidotic. They're going to have a fruity, sweet odor to their breath. If someone just has bad breath, halocious, okay, or they could smell of an ammonia. We want to talk about the patient's speech. Again, is it clear? Or is it slurring? Is it incoherent? You can't understand a word they're saying no matter how you try. Rambling. You can have the patient that's just going on and on and on. Do they have dysphagia or aphasia? If I have a patient with shortness of breath, I always like to mention if they can speak in full sentences. Because if they're having a hard time breathing and catching their breath, see how I just interrupted that? That's a big indicator of somebody's airway if they can speak fluently in a clear, full sentence. You can also note if the voice is hoarse. You want to look at their skin. Is their skin appeal healthy and robust? Is it flushed? They have fever. Is it cyanotic? They're having difficulty breathing. Are they ashen? Is their skin excoriated or jaundiced or pigmented? You also want to look at moles or other lesions that you might find. Those can be pigmented, could be a macule. They could have petechiae. They could have pediculi, okay? Skin can be mottled, discolored, dry, hot, warm, cool, calloused. When you're looking at rashes or abrasions, you could be looking at insect bites. You could be looking at tumors. There are so many terms here for integumentary. When you write that somebody's skin is intact, Think about all of these other adjectives you can be using to describe what that skin looks like. Because if somebody's unhealthy, you are going to see changes in their skin. Okay, and it's really good to make notes of those. Same thing with hair. Look at the disbursement of hair. Is it equal bilaterally? Do they have alopecia? Is the hair dry, coarse, and brittle? Is there seborrheic dermatitis or dandruff or cradle cap present? Okay. Pediculus capatis. Nicer term in a chart for head lice than writing head lice. I was a school nurse. I saw a lot of that. Are there nits present? Is there dandruff? Looking at fingernails. Fingernails can actually tell you a lot about your client's condition and if there's any underlying disorders. It's a nice little visual chart here to notice some differences in fingernails. Fingernails that are clubbing can indicate that they have hypoxia, usually long term. We see this a lot in patients who have COPD. Okay, if they have a spoon nail, where the nail is kind of concave like a spoon would be, that could indicate your patient has an iron deficiency. If I see spooning in a patient's nails, I want to look for a laboratory result, and I want to look at their H&H level to notice if they have an iron deficiency or if they look like they may have anemia. Nails that are very white and blanching can signify anemia as well. If they're really red, they could have polycythemia or have lupus. So there's a lot of different things that can indicate in their nails. Another one that you may see commonly, splinter hemorrhages. They look like red streaks, vertical streaks in the nail. That can be indicative of infective endocarditis. When we look at wounds and lesions, again, really trying to describe them in more detail. Is the skin torn or lacerated? Is there an avulsion? Is verruca present or warts? Or is there a furuncle or a pustule? Are wounds deep, perforating? Are they a puncture? Does it look infected? Is there necrosis present? Does the patient have hives or urticaria? Are they itching their skin? Are there signs of pruritus? When we're looking at the head, if someone complains of a headache or if there's a location, a wound, you want to notice the location, not just right side of the head, left side of the head. Is it the frontal region, temporal, occipital, basilar, parietal? Is it on the crown? Is the head overly large or overly small? Using terms macro or microcephalic. Looking at the eyes, we want to measure visual acuity. We also want to determine if there's any jaundice in the sclera. Are the eyes edematous? Is there ptosis of the lids? Is the patient complaining of double vision or diplopia? Is there a strabismus? Exophthalmos, do the eyes appear to be protruding? Okay, look at those pupils. Are they dilated? Are they constricted? Are they fixed? When we look at the ears, we want to note, is there any cerumen? Is the patient complaining of tinnitus or vertigo? Is there any discharge noticed from the ears? When we look at the nose, we want to notice, is there any epistaxis, any bleeding, or any clear discharge such as rhinorrhea? When we're looking at a throat, is there exudate, erythema? Do they have dysphagia or difficulty swallowing? When we're looking at tonsils, we don't want to just say if they're enlarged or the uvula. We want to talk about them in size and quantify that as a +1, +2, +3, +4. Very important, especially if we're following the care of a patient who has strep throat or sore throat, so we can indicate if they're responding to treatment or not. In the mouth, we want to look at the gums. Are the gums healthy, or is gingivitis present? Are there any abscesses? Does your patient have all of their teeth, or are they edentulous? Are there dental caries that are present? Do they have dentures or implants? If they have dentures, please note if they are partial or full, upper, lower, or both. They have cold sores. Do the lips appear pink, moist, dry, cracked, swollen, inflamed? Is any oral thrush present? When we look at a patient's chest, is it shrunken or atrophied? Is it deformed? Is it symmetrical? Do they have any pain when they move or when they breathe? This is just the visual inspection with your eyes, in addition to the lung sounds that you're going to listen to. When we're looking at circulatory, it's important to note a patient's heart rate, but it's also important to note, is it regular or is it irregular? That also applies to a pulse, whether you're checking a radial pulse or you're listening to an apical pulse. Is it regular or irregular? If it's irregular, is it constant or is it intermittent? Are you noticing that the rate is tachycardic or bradycardic? Is it weak or thready? When you're listening to heart sounds, are you hearing S1 and S2? That's your lub-dub. Is the patient reporting feeling dizzy or faint? That would be pre-syncopal. The patient actually faints, that's a syncopal episode. When we listen to heart sounds, really want to listen to all 5 locations. And if we are hearing abnormalities, a murmur, a click, a rub, you want to be able to document what location you hear that in. We like to use the term APETM. There's different ways to remember this acronym. Some people will say, all people enjoy Time magazine. I've also heard the acronym APE to man. In APEM, all physicians earn money. That one was to make you laugh. Okay. The locations here are also listed for where you would hear those heart sounds. When we're looking at our respirations, again, what do we see? Not what we're listening to just right away. Is your patient wheezing? Can you hear a change in wheezes or other breath sounds with inspiration or with expiration? Are they having dyspnea or orthopnea? Are there Cheyenne-Stokes respirations? Are the respirations deep or shallow, irregular? Are they stertorous? It's very noisy, very laborious. Okay, that also can refer to snoring. Is there apnea? Other descriptive terms you can look at here too: sighing, gasping, noisy. Then when we actually put our stethoscope and listen to those lungs, we want to look for, is there wheezing? Again, try to document, is the wheezing with inspiration, expiration, or with both? Are you hearing rails? Rails are in those smaller crackles. We hear those from fluid. It's fluid-filled alveoli. They do differ from rhonchi. I'm going to ask this question. In Sierra Leone, is there a drug called Mucinex? Do you have a commercial or a TV ad for Mucinex? No. I am going to send you a picture of an ad from a magazine and you'll know what I'm talking about. So in the United States, we actually have drug ads on our television and in magazines and newspapers. And they show this little green guy holding a suitcase. And by a little green guy, he looks like a gob of mucus. He's not very attractive looking. He's meant to be a big glob of mucus with a suitcase. And the slogan is moving it out of your airways. This drug is going to help move the mucus, hence why he carries a suitcase. If you're not sure if something is rails or rhonchi, remember rhonchi moves. Rhonchi comes with a suitcase. If you ask your patient to cough and your stethoscope is in the same place and you no longer hear that fluid, you know it was rhonchi because it just moved. Okay, versus rails, because if it's fluid, remember that's trapped in the alveoli and it doesn't move. It's a nice little trick. Okay. You also want to note if there's any stridor. And remember, stridor is in the upper airway over the trachea. Stridor usually indicates a foreign airway obstruction. Whether the patient has swallowed something and it's stuck in their throat, or whether they're having swelling in the upper airway, which can happen like with an anaphylactic reaction, and that trachea itself is closing due to inflammation. But that's where you're going to hear stridor. You also want to assess for crepitus, which is free air in the chest cavity. Crepitus sounds like crispy rice when you touch the skin. It makes a crackling noise. Do you have Rice Krispies as a breakfast cereal? Anyone know what Rice Krispies are? Or a Nestle Crunch candy bar?
Yeah.
Crispy rice. It feels like that underneath the skin. Best way to describe that. And there's an order here for when you're listening to your lung sounds. Again, you really want to go side to side and using a snake-like pattern back and forth, both anterior and posterior. We can also describe a patient's cough in greater detail. Is it persistent? Is it productive or non-productive? Is it a dry cough, a hacking cough? Frequent. I actually like to document how many times my patient coughs per minute. If I'm at the bedside and they're coughing 4 to 5 times per minute, does that tell you that patient is coughing an awful lot? Absolutely. Versus if the patient coughs once every 3 to 4 minutes, that would be an occasional cough. So again, it gives you a unit of measurement. So when the next nurse comes in, or you yourself return the next day, is your patient the same, getting better, or getting worse? Can also describe a cough as spasmodic or whooping, paroxysmal. Is it tight? Is it loose? Is it painful? Different terms you can use here, much more descriptive than just saying the patient presents with a cough. When we're looking at an abdomen, we want to know, is it enlarged? Is it protruding? Is it edematous? Do they have any bruising, ecchymosis, any petechiae on the abdomen or purpura? Does it feel hard or rigid? Or is it relaxed and flat? Is it tender or sensitive to touch? Is there a rash present? Do they have flatulence? Nicer term to use than saying your patient is gassy. Are they guarding their abdomen, or is there any rebound pain or tenderness? Their bowel sounds, instead of just saying they're present, are they normoactive or hyperactive or hypoactive? I didn't put this down here, but do they have boroborigami? That's loud, rumbling stomach noises when you're hungry. I get boroborigami when I'm hungry all the time. I think you can hear my stomach growl across the room. But again, that says this patient's GI tract is working and it's functioning well. When we talk about stool, we don't want to just say they had a small bowel movement or a large bowel movement. You want to describe it. Is it soft? Is it firm? Is it liquid? Was it mucoid? Is it dark brown or mustardy yellow? Is it pale in color? Does it have a green tinge to it? Okay. Can definitely get some more quantifiers there with your patient's GI status. When we're looking at their abdominal regions, again, try to be more specific. Whether you use right and left, upper and lower quadrants, or whether you expand it a little bit more. Is it in their umbilical region or in their hypogastric region? When we're talking about urinary and again, instead of just saying the patient voided 500 cc's, give me some more quantifiers for that. What color is it? Is it pale yellow, straw colored? Is it dark yellow or tea colored? Did the patient complain of a burning sensation? Is there any blood present in the urine? Okay. Do they have polyuria, increased frequency, or nocturia, frequent night voiding? Looking at reproductive for both male and female. Again, here's just some more appropriate terms to use when it comes into our documentation. Musculoskeletal. Do they have paraplegia, hemiplegia? Is their muscle movement flaccid? Do they move all extremities equally, unequally? Okay, when we're looking at sensation, is there tingling, burning, stinging, prickling? When we're talking about range of motion, look at their joints, flexion, extension, supination, rotation. Is there crepitus when they move their joints, cracking or creaking? How many times have you moved a patient's elbows or knees? I hear it a lot in knees, and it makes that cracking or creaking noise. Okay, that's crepitus. Looking at somebody's back. Again, just really focusing in on the different regions. Lumbar, sacral, intrascapular. Do they have kyphosis, a humpback as they're leaning forward, or a swayback, a lordosis? When we're talking about pain, really trying to describe it. Is it a sharp pain? Is it a gnawing pain, a burning pain, a cramping pain? Is it localized? Does it radiate? Or does it stay in one location? Does something make it worse? Does something make it better? Muscle aches are myalgias. Joint aches are arthralgias. When we talk about the psychosocial aspect of our patient, again, does your patient make eye contact with you? Do they appear indifferent or apathetic? Do they appear suspicious or distrustful? You might see that displayed when somebody has drug-seeking behaviors. But we don't want to note in our chart or say we suspect something, but we can say that the patient is acting suspicious and distrustful. That would be a proper way to put that in the chart. Are they belligerent, quarrelsome, disagreeable? Does the patient appear anxious or fearful? Or are they cheerful and optimistic? Do they weep openly if they're appearing sad? Or are they laughing boisterously? Great way to be able to validate what that patient's feelings are without saying, without being suspecting, okay, or using your opinion. It's also important to note if a patient doesn't recall a certain time frame, if they have a gap in time of their memory. So this is just a small sheet of some ideas and suggestions that you can use. I'm going to stop sharing now to help enhance your documentation